Thank you so much. Unfortunately, I cannot speak Spanish, so you will forgive me. I can only speak English. My topic is regarding augmented reality. I don't know if any of you have experience with this kind of modality, which in my opinion will be significantly diffused in the next few years. I have no conflict of interest. My agenda will include a differentiation between virtual and augmented reality, the so-called mixed reality, how it is called now, clinical challenges, technical challenges, current technology available, and the very first clinical outcomes. Let me start with briefly with some clinical challenges. Imaging nowadays enables to visualize an increasing number of small lesions, especially in hidden locations. And the second point is that the outcomes of the image-guided therapies are expected to be continuously improving. Today I will just treat the therapies, but the same topics can be also for biopsies, any kind of biopsy in any part of our body. So precision is becoming increasingly mandatory. In addition, we have a constant increase of the image-guided therapeutic procedures with the increasing need to facilitate their use, what we call democratization, and to improve the outcomes, particularly for young operators. Training is particularly important for young people. Young operators are very skilled in the use of technologies. We know very well about video games and all the other things. So young people learn very quickly this kind of new technologies. So there is a need for a technically easy combination of the real world with a virtual object superimposed. You know very well virtual reality. Virtual reality is an immersion of the user in an artificial world digitally created usually through smart glasses with very limited or not at all direct interaction between the real world and the user. So it is mostly used for surgical planning and for simulation, but not for guiding any kind of interventional procedure. Augmented reality is, on the contrary, the perfect superimposition, but with the possibility to perform guided maneuvers based on the visualization. We combine the real world, which is the operating room, the intervention instrumentation, and so on, with the virtual objects, hidden organs, hidden targets, and so on. And this can be achieved with several systems. The most commonly used are the head-mounted devices, the so-called smart glasses. But we can also use smartphones or tablets or video projectors. Nowadays, in my opinion, smart glasses are greatly improving, so they are becoming more and more useful for this kind of procedures. How can we use augmented reality? First of all, this is an excellent paper published 3 years ago by an English group. We can use just to visualize precisely anatomy superimposed on the imaging. This is an example of a vascular surgery in which we have the 3D holographic view of the vascular system superimposed over the real anatomy without any kind of radiation. So avoiding the continuous use of CT, for example, to understand where are the blood vessels of this patient. But we can also use, in this kind of situation, for guiding, for indicating the point of entry through the body of the fibers of irreversible electroporation, has been already described in the literature, and also for some cases of prostate interventions based on the image-based planning. The most complicated section is the second, so the direct guidance of interventional procedures, biopsies, ablations, any kind of percutaneous treatments. We are starting now a study on bone biopsies performed without using CT, simply using augmented reality. But I will not talk about that today. So the system is composed, it's very simple. We have fiducial points applied to the patient's skin prior to CT scanning, or using smartphones, for example. The visualization of the target in 3D, if you use the smart glasses, or in 2D, if you use smartphones or external screens. We need to see the trajectory line which connects the interventional device to the target. We need to visualize the major blood vessels, and we need absolutely to visualize the interventional device and the target touching phase. When we touch exactly the target changes its color, suggesting that we have exactly hit the right position. For moving organs, the breathing cycle of the patient has to be synchronized with the operator's movements. That's why we started our experience 2 years ago using liver as our organ, because liver moves. We are seeing that, for example, for bone lesions, it is much easier because bone do not move. And I will just present you some results of our first experience. This is the system produced by Endocyte in Milan. We use radiopack sensors applied to the skin of the patient, sensors with no repetitive pattern. It means QR codes, applying before applying the CT scans. This is the system, the complete system, very low cost, a computer, a screen, and the smart glasses. On the smart glasses, we have applied some 2 mini cameras, one for each eye. In addition, we have the radiopack sensors with no repetitive pattern, so it means QR codes, applied to the coaxial needle used as ablation device introducer. Very important, the software. The software is a little bit complex. We have several types of software together. Software for 3D reconstruction, software for marker co-registration, software for antenna calibration, for the AR interface with the smart glasses, and for the PC. This is the result, what the operator sees, simultaneously the real body of the patient and the internal position of the patient with a single image. And as you can see here, we have the visualization, what the operator can easily see through the smart glasses. In addition, this system works perfectly with the ablation confirmation software, which, in my opinion, should become mandatory in the next few years for all the guided ablations. Otherwise, we will not be able to assess exactly the volume of our necrosis compared to the volume of the lesion before treatment. We started with an experience in cadavers metastasis. As you can see here, an example of a small target, small lesion down the liver, adequately targeted with excellent result. And the distance between the needle tip and the geometrical center of the target resulted to be 2.5 millimeters, which is not bad. Absolutely, it's a good result. From that time, we moved from cadavers to real patients. This is just a movie experimental done with our co-workers. These are the skin, the markers to be applied on the skin, radiopack markers, simply applied, touching the skin. When this is completed, we can perform the CT with these radiopack markers. They allow the identification of the patient correctly. At the end, in terms of 5 to 6 or 7 minutes, we have the interface of the CT showing the patient lesions, for example. At that point, we can segment automatically or semi-automatically the lesion or the lesions, again, very quickly. And when we are ready for that, we can wear the smart glasses. The planning phase before, as you can see, and use of the smart glasses. When the operator wears the smart glasses, can see simultaneously, as you can see here, the external and the internal part of the patient. Then we use the coaxial needle to reduce the possible deviations of the biopsy needles or the ablative devices. And at that point, we are ready to start the procedure. When this is the operator who wears the glasses, he can see the real world simultaneously, but he can also see the inside of the patient. This is the liver of the patient, the real liver of the patient, with the planning visible during the interventional procedure. So we have published this year the very first paper in the world regarding the thermal ablation of liver tumors guided by augmented reality. 9 HCCs and 6 metastases from breast and pancreatic carcinomas in 8 patients. The size range was between 7 millimeters and 3 centimeters. The mean was 1.5 centimeter. 7 tumors were visible also with ultrasound, but we did not use ultrasound, and 8 were totally undetectable with sonography. Microwave in 14 patients, RFA in 1. CT scans achieved as I showed you before, and the guidance was only with augmented reality. What were our aims? To determine the time for segmentation and 3D reconstruction, the time to reach the target, and the distance of the device tip to the target geometrical center. And these were the results. First of all, technical success was achieved in all cases, and the time for segmentation and 3D reconstruction was an average between 12 and 17 minutes. The mean was 14 minutes. Nowadays, is even shorter than that. These are the distance from target, time to reach the target, and the modality used for the measurement. And it is clear that the precision was very good because the average distance from the target center was 3.2 millimeters. And the time needed to reach the target was, in average, 4.3 minutes, which is really a reduced time compared to the time usually needed for CT guidance. We are testing now the system to guide procedures into the osteoid osteomas. As you know, these are millimetric lesions, sometimes very complicated to target percutaneously with CT, and we have a dramatic reduction in the number of CT scans for those procedures. Just 2 examples, patient with single HCC, this is the procedure done. This is what the operator sees. The needle is visualized in green. The target is up there, as you can see. When the needle approaches the target and hits the target changes color, becomes red. So it has been completely hit, and this is the result of the procedure. This is another case of a very difficult lesion, hepatic metastasis from pancreatic tail carcinoma. This was the lesion. This was the lesion on scintigraphy, and this is the invisibility of the lesion with sonography. Preparation of the patient, as I showed you before, the 3D visualization through the smart glasses, the line which automatically connects the center of the target to the tip of the needle, and we have simply to follow the line indicating until we hit correctly the target, as you can see there. This is the site of the target, and this is the control with ultrasound to understand where the needle was, but not with using ultrasound. This is the result at the end. And automatically, the machine can give you through the ablation fit software, the volume of necrosis in blue, the lesion in orange, and the margin in green, demonstrating the precision of the needle. This is a software which uses non-rigid registration. I underline that because it is mandatory to use this type of software to adequately evaluate. Just to mention, 3 years ago in Innsbruck, during the meeting of my friend Reto Bale, a test was made. 38 radiologists, 19 expert, 19 not expert at all, were put in front of 10 cases of hepatocellular carcinomas already treated, just to evaluate if the radiologists were able to look with their eyes if the treatment was adequate or not, and if there were recurrences on. And 44% of all the radiologists were wrong. And incredibly, the wrong results were the same for expert and non-expert radiologists. It means that the problem is not in our eyes, it's in the system. We should improve the system. I fully believe that in the next 3, 4, 5 years, this kind of software will become mandatory to demonstrate to our colleagues, in particular to our surgeons, who have always claimed that our results are just how can I say, preliminary, just evaluated simply, while their results are evaluated by pathologists, so precisely with margins clearly demonstrated. To conclude, are there limitations? I should say there were limitations nowadays. The field of view is progressively increasing using smart glasses. The registration mismatch nowadays is below 5 millimeters, as I showed you. The cyber sickness, which was created at the very beginning using the smart glasses, now is almost completely disappeared due to the improvement of the system. The user-dependent calibration is no longer needed. And the single operator vision is not a limit, because you can connect as many screens as you like. You can also connect your colleagues in America or in UK, and they can see simultaneously what the operator can see at that specific time in order to improve also the training, as it is underlined also by some recent papers. The advantages: accurate planning, significant reduction of CT scans, usability both in the ultrasound room and in CT room. We prefer to use it, of course, in the CT room, for every organ, with any biopsy needle and any ablation device, with immediate visualization of the treatment outcome, particularly well perceived by junior staff members. So we feel that the augmented reality can really be a reliable and precise modality for the guidance of thermal ablation. I suggest you to read this paper, recent paper from the group of United States, of my friend Raul Appot, underlining the importance of augmented reality for the education and training, particularly of young operators. This is the result. And just to conclude, two important comments. One by Tim Cook, CEO of Apple, as you know. Augmented reality will happen in a big way, and we will wonder, when it does, how we ever lived without it. The second is from our great friend Brad Wood from Bethesda, National Institute of Health. The AR revolution is imminent, published in Interventional News. Thank you very much for your attention.